Pericardial Disease. 10/2012. Medslides.com. Pericardial disease, acute pericarditis, chronic relapsing pericarditis, constrictive pericarditis, cardiac tamponade, localized and low-pressure tamponade, restrictive cardiomyopathy. 998. Medslides.com. Pericardial anatomy, 2 major components: serosa, visceral pericardium, mesothelial monolayer facilitate fluid and ion exchange. Fibroa, parietal pericardium, fibrocollagenous tissue. Pericardial fluid: 15 to 50 milliliters of clear plasma ultrafiltrate. Ligamentous attachments to the sternum, vertebral column, diaphragm. 998. Medslides.com. 998. Medslides.com. Pericardial physiology. Not needed to sustain life. Physiologic functions: limit cardiac dilatation, maintain normal ventricular compliance, reduce friction to cardiac movement, barrier to inflammation, limit cardiac displacement. 998. Medslides.com. Pericardial inflammation pathogenesis. Contiguous spread: lungs, pleura, mediastinal lymph nodes, myocardium, aorta, esophagus, liver. Hematogenous spread: septicemia, toxins, neoplasm, metabolic. Lymphangetic spread: traumatic or irradiation. 998. Medslides.com. 998. Medslides.com. Pericardial inflammation pathology. Inflammation provokes a fibrinous exudate with or without serous effusion. The normal transparent and glistening pericardium is turned into a dull, opaque, and sandy sac. Can cause pericardial scarring with adhesions and fibrosis. 998. Medslides.com. Pericarditis. 998. Medslides.com. Acute pericarditis, common causes. Outpatient setting. Usually idiopathic. Probably due to viral infections. Coxsackie A and B, highly cardiotropic, are the most common viral cause of pericarditis and myocarditis. Others: viruses, mumps, varicella zoster, influenza, Epstein-Barr, HIV. 998. Medslides.com. Acute pericarditis, common causes. Inpatient setting: T equals trauma, tumor, U equals uremia, M equals myocardial infarction, acute, post, medications, hydralazine, procaine, O equals other infections, bacterial, fungal, TB, R equals rheumatoid, autoimmune disorder, radiation. 998. Medslides.com. Acute pericarditis diagnostic clues. History: sudden onset of anterior chest pain that is pleuritic and substernal. Physical exam: presence of 2 or 3 component rub. ECG. Most important laboratory clue. 998. Medslides.com. Chest pain history: pericarditis versus infarction. Common characteristics: retrosternal or precordial with raditine to the neck, back, left shoulder or arm. Special characteristics: pericarditis more likely to be sharp and pleuritic, with coughing, inspiration, swallowing. Worse by lying supine, relieved by sitting and leaning forward. 998. Medslides.com. Heart murmurs of pericarditis. Pericardial friction rub is pathognomic for pericarditis. Scratching or grating sound. Classically 3 components. Presystolic rub during atrial filling. Ventricular systolic rub, loudest. Ventricular diastolic rub, after A2P2. 998. Medslides.com. Acute pericarditis ECG features. Saint segment elevation. Reflecting epicardial inflammation. Leads 1, 2, AV, and V3 V6. Lead AV usually shows Saint depression. Saint concave upward. Saint in AMI concave downward like a dome. PR segment depression, early stage. T-wave inversion. Occurs after the Saint returns to baseline. 998. Medslides.com. 998. Medslides.com. 998. Medslides.com. 998. Medslides.com. Acute pericarditis management. Treat underlying cause. Analgesic agents. Codeine 15 to 30 mg Q 4 to 6 hours. Anti-inflammatory agents. ASA 648 mg Q 3 to 4 hours. NSAID, indomethacin 25 to 50 mg ct. Corticosteroids are symptomatically effective, but preferably avoided. 998. Medslides.com. Chronic relapsing pericarditis occurs in a small percent of patients with acute idiopathic pericarditis. Steroid dependency requiring gradual tapering over 3 to 12 months, NSAIDs, analgesics, and colchicine may be beneficial. Pericardiectomy for relief of symptoms is not always effective. 998. Medslides.com. Dressler's syndrome described by Dressler in 1956. Fever, pericarditis, pleuritis, typically with a low-grade fever and a pericardial friction rub. Occurs in the first few days to several weeks following knee or heart surgery. Incidence of 6 to 25%. Treat with high-dose aspirin. 998. Medslides.com. Acute pericarditis differential diagnosis. Acute myocardial infarction. Pulmonary embolism. Pneumonia. Aortic dissection. 998. Medslides.com. Case Study 1. A 56-year-old man develops recurrent chest discomfort 5 days after an anterior myocardial infarction, which was managed initially with tissue plasminogen activator. The pain is sharp and positional, radiating toward both clavicles. It is different from the pain associated with his infarction. 998. Medslides.com. Case Study 1. Physical exam, a febrile no pericardial friction rub ECG, mild PR depression in lead to no significant change in the evolution pattern of his Q-wave anteroseptal myocardial infarction. 998. Medslides.com. Case Study 1. The most appropriate therapy for this patient is salicylates, indomethacin, corticosteroids, colchicine. 998. Medslides.com. Case Study 2. A 36-year-old woman presents to the ER for the second time in a week with pleuritic chest and left shoulder discomfort and a low-grade fever. She had been in an argument with her boyfriend 6 days earlier, during which he grabbed her by both shoulders and shook her violently. 998. Medslides.com. Case Study 2. HR 82, BP 9470. Left iris is green, right is blue. She is slender, has a straight back, long fingers, high arched palate, and slight pectus excavatum. A pericardial friction rub is present. 998. Medslides.com. Case Study 2. A chest radiograph shows an increased cardiac silhouette and a small left pleural effusion. ECG shows NSR with diffuse J-point elevation and PR segment depression in lead 2. 998. Medslides.com. Case Study 2. Which one of the following tests should you order? An erythrocyte sedimentation rate. A creatine kinase determination. An echocardiogram. an anti-nuclear antibody. AD dimer. 998. Medslides.com. Constrictive pericarditis. Rarely develop after an episode of acute idiopathic pericarditis. More likely to develop after subacute pericarditis with effusion that evolve over several weeks. More frequent after purulent bacterial or tuberculous pericarditis. 998. Medslides.com. Constrictive pericarditis in the United States. Idiopathic. Radiotherapy. Cardiac surgery. Connective tissue disorders. Dialysis. Bacterial infection. 998. Medslides.com. Constrictive pericarditis. 998. Medslides.com. Tuberculous pericarditis. Incidence of pericarditis in patients with pulmonary TB ranged from 1 to 8%. Physical findings: fever, pericardial friction rub, hepatomegaly. TB skin test usually positive. Fluid smear for TB often negative. Pericardial biopsy more definitive. 998. Medslides.com. Constrictive pericarditis physical findings. Jugular veins. Prominent X and Y descent. With inspiration, Kussmaul's sign. Lungs, possible pleural effusion. Heart, diastolic pericardial knock. Abdomen, ascites, pulsatile liver. Extremities, peripheral edema. 998. Medslides.com. Constrictive pericarditis diagnosis. Often not recognized in its early phases by exam, X-ray, ECG, echo. Tendency to overlook elevated JVP. Subacute chronic. Diastolic knock +++. Kussmaul's +++. Paradoxical pulse ++++. 998. Medslides.com. Constrictive pericarditis catheterization findings. Right and left heart pressure are measured simultaneously. Right and left ventricular diastolic pressure are elevated and nearly equal, may show classic square root sign. RA pressure has steep X and Y descents and may rise during inspiration, Kussmaul's sign. 998. Medslides.com. Case Study 3. A 42-year-old man presented because of increasing abdominal girth and lower extremity edema. A decade ago he underwent treatment for Hodgkin's disease that included mantle field radiation therapy and MOP chemotherapy. 998. Medslides.com. Case Study 3 HR84, BP 170 JVD not observed at 45 degrees. Absent the vocal frematus at right base. Heart sound is distant. An early mid-diastolic sound. 3+ pitting edema bilaterally. 998. Medslides.com. Case Study 3 What is the most likely diagnosis? Effusive pericarditis. Occult constrictive pericarditis. Constrictive pericarditis. Idiopathic dilated cardiomyopathy. Restrictive cardiomyopathy. 998. Medslides.com. Types of effusive fluid. Serous. Transudative, heart failure. Suppurative. Pyogenic infection with cellular debris and large number of leukocytes. Hemorrhagic. Occurs with any type of pericarditis, especially with infections and malignancies. Serosanguinous. 998. Medslides.com. Diagnostic evaluation chest X-ray echocardiography. Usually requires greater than 200 milliliters of fluid. Cannot distinguish between pericardial effusion and cardiomegaly. Echocardiography. Standard for diagnosing pericardial effusion. Convenient, highly reliable, cost-effective. False positives, N mode, left pleural effusion, epicardial fat, tumor tissue, pericardial cysts. 998. Medslides.com, non-compressing effusion. Asymptomatic unless they are large enough to compress adjacent organs. Dysphagia, cough, dyspnea, hoarseness, hiccups, abdominal fullness, nausea. 998. Medslides.com, ECG and pericardial effusion. Diffuse low voltage, amount of fluid, electrical conductivity of the fluid, electrical alternans, alternating amplitude of the QRS, produced by heart swinging motion. Also seen in PSVT, HTN, ischemia. 998. Medslides.com, cardiac tamponade. Decompensated cardiac compression from increased intracardiac press. 998. Medslides.com, cardiac tamponade early stage advanced stage. Mild to moderate elevation of central venous pressure. Advanced stage. Intrapericardial pressure, ventricular filling, stroke volume. Hypotension. Impaired organ perfusion. 998. Medslides.com. Beck's triad described in 1935 by thoracic surgeon Claude Beck. 3 features of acute tamponade. Decline in systemic arterial pressure. Elevation in systemic venous pressure, for example distended neck vein. A small, quiet heart. 998. Medslides.com, cardiac tamponade bedside diagnosis. Elevated jugular venous pressure. Paradoxical pulse. 998. Medslides.com, pulsus paradoxus. An exaggerated drop in blood pressure with inspiration, greater than 10 mm of mercury. Tamponade without pulsus. Atrial septal defect. Aortic insufficiency. LVH with LVAD. Pulsus without tamponade. COPD, RV infarct, pulmonary embolism. 998. Medslides.com. Echocardiography pericardial effusion cardiac tamponade. Highly reliable. Cardiac tamponade. RA and RV diastolic collapse. Reduced chamber size. Distension of the inferior vena cava. Exaggerated respiratory variation of the mitral and tricuspid valve flow velocities. 998. Medslides.com. Pericardiocentesis diagnostic tap therapeutic drainage. Usually not indicated. Rarely have positive cytology or infection that can be diagnosed. Therapeutic drainage. Indicated for significant elevation of the central venous pressure. 998. Medslides.com. Pericardial window balloon dilatation of a needle pericardiostomy. Subxiphoid surgical pericardiostomy. Video-assisted thoracoscopy with localized pericardial resection. Anterolateral thoracotomy with parietal pericardial resection. 998. Medslides.com. Localized and low-pressure cardiac tamponade. Localized tamponade due to loculated pericardial effusion. Low-pressure tamponade due to relative intravascular volume depletion. 998. Medslides.com.